So maybe this certainly will not be the end of treatment options in achalasia. And if you look into pathophysiology, which also, of course, is developing, we know that achalasia is probably maybe caused by some virus, we don't know which virus, that in a genetic predisposed individual, this gives rise to inflammatory reactions with cytokine production, inflammatory infiltrates, and then apoptosis of the neurons. And finally, and that's when we see the patients, of course, when they have this myenteric plexitis and they have absence of peristalsis and impaired relaxation of the lower esophageal sphincter. So people are thinking already now of doing stem cell transplantation. Maybe we should treat them with biologicals, anti-TNFs, who knows? But of course, the thing is that we only find the patients at the last stage. Okay, well, I could just ask to the panel here, who would do just a simple myotomy, endoscopically, of course, or who would prefer ZPUM, what David is going to present us. Aren't you, David?
Correct. I'll give my answer first, Danny, and then you can talk about it. It's much easier, and you'll see why when I show you the septum in a tunnel. It takes very little time to do a zenkopoem, and you get full access to the muscle, which you can cut right down on as far as you can go. And I think you're never sure when you're doing the standard technique how far you can go. If you get bleeding, it's more difficult to see where the vessel is, etc., etc. So I think the submucosal approach has advantages. If you know how to do it, it's not much more difficult. But I listen to the advice of others, yeah. Okay. Someone from the panel having an idea about this?
Maybe everyone can just comment.
I'm sorry?
Just comment 1, 2, 3, 4.
Okay.
Yeah, I would still do the normal procedure.
Inject.
But I think there are some advantages about visibility and treating complications. And the results are the same. Maybe we should switch to the ZPUM procedure.
We know from this excellent study from Thomas Roche and colleagues, multi-center study, that the results in long-term follow-up between POEM and laparoscopic helomyotomy are the same. And they're also the results between POEM and balloon dilatation based on Paul Focken's study. POEM is certainly superior. You need to do many more balloons to get to the same results that you would achieve with a single POEM. And this is a meta-analysis of laparoscopic helomyotomy versus POEM. And you can see that the results are, again, very comparable between POEM and laparoscopic helomyotomy in long-term follow-up. Of course, the limitation of POEM is reflux. I have to say that we preserve the longitudinal muscle fibres, which tend to split apart, and the oblique fibres at the cardia, the collar sling fibres, and we tend not to see much in the way of reflux, and certainly not symptomatic reflux in most of the patients. But we do have to counsel them against weight gain, which can really contribute to symptomatic reflux. And these are the long-term data showing that the initial response, response is sustained. The treatment is in fact very durable. But the great benefit is that you can redo it should the patient have a problem. I think the other thing is to be careful in the tunnel not to have excessive bleeding, because that can complicate the outcomes as well. You can cause scarring and then later relapse. So it's very important to keep all the bleeding, or to avoid bleeding totally, is what we aim for. It also works for sigmoid esophagus as a consequence of achalasia. These are the results from several studies. And as I showed, it can rescue other procedures. This is a range of series with the proportion of naive patients, and you can see, and those who've had previous treatments, and you see here the favourable outcomes in the overwhelming majority. So I think POEM has been a revolutionary intervention for the management of achalasia.
Yes.
Oh, in which situation?
In any situation, if it's an achalasia type 1 or 2. In a type 3, you guys win. I completely agree with that one.
But you don't believe the New England Journal study?
I do, and I don't do Hellertore anymore.
Yeah.
For about 5 to 6 years now, since these guys are performing our POEMs. I think you have to inform your patient, like your table shows. There is a risk of having the need of a fundoplication. It's a very small risk, really agree on that. But there's still an issue of 40 to 60%.
Okay, so. Tim?
Absolutely, yes. We still do chromatic dilations, absolutely.
Tim is from Leuven,
We will not do the POEM in type 3 achalasia, for that I agree, but for type
the dilation,
type 2,
yes.
we will counsel the patient.
Okay.
Not relevant for the contents of this talk. The learning objectives have already been discussed. We will discuss symptoms of gastroparesis, the limitation of the current evidence for GPOEM, and also how we should select patients for GPOEM with the current evidence. Danny has already alluded to this, but it's very important that we start with a definition of gastroparesis. So it's a combination of symptoms combined with delayed gastric emptying in the absence of an obstruction. But what are these symptoms? And there's a lot of misunderstanding about this. So if we look at symptoms in patients with gastroparesis, this is the list. But the most important one, the cardinal symptoms in gastroparesis, are really nausea and vomiting, which are present in a majority of patients. Excuse me. However, the problem is that there is indeed a lot of overlap with functional dyspepsia, and you see postprandial fullness, early satiation, bloating, and epigastric pain. And that's where the confusion comes from, because this is really not gastroparesis, this is functional dyspepsia. And the overlap is really high. Patients with functional dyspepsia can have delayed gastric emptying, but this is probably not relevant for their symptom generation. So this is functional dyspepsia. As you know, in Rome 3 and confirmed in Rome 4, there are two big subgroups. There is a postprandial distress syndrome with the postprandial fullness and early satiation, and this is where there is the overlap with gastroparesis. So it sounds simple. You could just look at the symptoms and do gastric emptying. The problem is that gastric emptying is not a very stable measurement. So this is really a landmark study published in Gastro last year from the US, where about 1,000 patients were studied with upper GI symptoms.
Reflux ulcer. What to do with it? High dose PPI?
Well, we would consult our laparoscopic esophageal surgeon.
Okay, we have one here.
We did consult on this patient. It's the first one, by the way, which is kind of a surprise. Oh, it's not a surprise. It's according to the literature, of course. I have a question. Would you do a manometry in this patient, and pH monitoring in this patient? That was my question to David.